Basically, this course is a course for the general ophthalmologists and the postgraduates who find it difficult to interpret strabismus evaluation and treatment modalities. So we have an expert panel of strabismologists who will be going through the presentations, and you can ask any doubt, whatever, even the silliest doubt you might be there, so that we can try to resolve all the doubts. So we'll start off with the first most important topic, because the whole of strabismus is based on evaluation. So evaluation is the key for diagnosis as well as management, and without a proper evaluation we will not be having any meaningful treatment modalities possible. So I request Dr. Vidya, who is a consultant pediatric ophthalmologist. She is practicing at Shankara Eye Hospital, Bangalore. So she will be telling to us about how to evaluate a child with strabismus.
Good afternoon, everyone. First of all, I thank Dr. Arun Sampriti sir for this opportunity to speak here. So my topic is on evaluation of strabismus is not difficult. So when we see the patients of strabismus, it is like a confused pieces of a jigsaw puzzle. So there is a systemic way of approach of these children and adults with the strabismus. When you go with that approach, the jigsaw puzzle gets solved and you will get a perfect picture. So to start with, we need the tools for the evaluation. So we should have a multiple colorful, lighted and the sound making toys, then colorful pictures on the wall, the rhymes playing on the screen, then of course we need a loose prisms or a prism bar with the near target. So the evaluation starts with the history. The age of onset is very important in these children. We have to find out which age the squint has started. Either the patients may say, or you may go and search for the family album. You will get to know exactly when the onset has started. So from this we will come to know what exactly the squint we are dealing with. Then comes the onset and the course. Whether it's an intermittent onset, whether it is constant, what is the course of the deviation, we should elicit from the parents. Birth and developmental history plays an important role here, because the children with a low birth weight, with a prematurity, with any neurological developmental delay happening, they are all more prone for the strabismus in the future. Past ocular history, we have to ask specifically for the history of patching, history of glasses, any other history of trauma, any ocular surgeries. All these things should play an important role in the diagnosis too. Then family history of strabismus, make them more prone for getting the strabismus in the children, and also family history of high myopia, glasses, any surgeries, all these things need to be asked. The evaluation, after the history, it should go into the sensory evaluation. Before we dissociate the eyes for the visual acuity, we should first elicit how much is the stereopsis for the child, how much is the binocularity the child is able to see. So we can use the charts like a TNO chart, a Titmus flight chart to elicit the stereopsis here. Here you can see the child is wearing the polarized glasses, and the child is asked to touch the wings of the fly, and the child is able to do. So it means the child's stereopsis is far better. Then we go out with a Wirth-Podolsky test, which is a dissociating test. So from this we will come to know whether the child is having a suppression, a binocularity, a diplopia, or an anomalous retinal correspondence. Then comes the visual acuity evaluation and refraction. We have to use the age appropriate charts. With this we will come to know the refractive errors of the child, and we have to identify the accommodative component. We have to assess the amblyopic status of the child as well. So observation starts from the time when you are seeing the child entering your room. So keep watching the child for any abnormal head posture the child is having. And when the child is seated in the chair, keep watching for any orbital asymmetry, any epicanthal folds or the angle kappa, which may give us an idea about the pseudostrabismus. Here you can see both the children came with the complaints of strabismus noted in the child. The first child you can see, the first child you can see there is a broad nasal bridge. Even in the second picture showing a broad nasal bridge. We will come to know which child had the squint. Then comes the examination of the ocular alignment. We start with the fixation pattern of the child. So we go ahead and check for the central, steady and the maintained fixation. Central, you put the torch in front of the eyes and then check for the corneal reflexes whether they are in the center of the cornea or not. Then steady to look in for any nystagmus which will categorize them into an unsteady fixation. And maintain fixation if the fixation is remaining to be maintained even with the uncovering the other eye. So the the cover can be done with either the finger or the occluder or your hands. The Hirschberg test, you put the light in front of the eyes and look for the corneal light reflex in both the eyes. 1 millimeter of displacement will give about 15 prism diopters of deviation. It is very useful in uncooperative patients and the children. Modified Kremski test, we place a prism in front of the fixing eye to center the corneal reflex and get to know approximately how much is the deviation of the eyes. We do this test with the patients with a low best corrected visual acuity in very uncooperative patients. So here in this patient you can see there is an esotropia on the right eye. The patient had a low visual acuity of about 5/16 in the right eye, so I have placed a base out prism to neutralize the corneal reflexes in both eyes. Cover test. Cover test, we place the cover in one eye, look for the deviation in the other eye. So when the eye moves from outward to the inward, we know that there is an exotropia and vice versa for the esotropia. Then uncover test, you uncover the eye and look in for the deviation happening with the uncovered eye. It gives us an idea about the latent strabismus. Then we have to go ahead and do the alternate cover test, which will bring us the total deviation present in the child. So we alternately cover each eye without allowing the fusion so that we get to know the total deviation. So in this video, first we cover one eye, see the movement in the other eye. Then you can see the eye is moving from out to in. It means there is an exotropia of the eyes. Then you do the alternate cover test. Don't allow the fusion to happen. Then place the prisms in both eyes. Here I have chosen to place the prism in both eyes because the deviation was coming to be more than 50 prism diopters. So this patient had an exotropia of about 65 prisms. So I placed in both eyes about 30 and 35 in each eye. Then I have started doing the cover test. Here the basic thing is the prisms need to be placed with the apex towards the direction of deviation of the eye. So since this is an exotropia, I have placed a base out prism and started measuring the base in prism and started measuring the deviation. The end point of the prism cover test will be you have to neutralize the eye should not move or the eye may start moving in the opposite direction. You can see the reversal of the movement that is considered to be the end point. Once it is done in the primary gaze for the distance, you do it for the near also. So you do it for the near. The near deviation should be measured only with the accommodative target, not with the torchlight. So here the patient is holding the accommodative target about 33 centimeters. Then I am measuring the squint here. Then comes the extraocular movement assessment. So starts with a version where we ask the child to move with both eyes together, see for the actions in all the direction of the muscle. You can see the child is able to move the eyes in all the direction. With a fixating target, you can make the child. But when the child is moving into the left gaze, you can see the left eye is not moving into abduction. So in these cases, we would perform a duction. So close one eye, the child was very resistant for occluding the right eye. So with that, we got the movement in the left eye too. So you can see the child has moved the left eye. It means the movement is full in both eyes. Because of the cross fixation, the child is fixing with the right eye even on the left gaze. Then we go ahead with a special test for squint evaluation, namely the diplopia charting, Hess charting. These are mainly useful for the paralytic and the restrictive strabismus. It identifies the specifically affected muscle, especially the paralyzed muscle. Then we go ahead with the double Maddox rod test, which will give us the degree of torsion the patient has. And it's mainly useful for the oblique muscle dysfunction. Then a force duction test, which is done under the topical anesthesia, which will give us an idea about the restriction the muscle is having. So then the force generation test, which will give us an idea about the strength remaining in the paralyzed muscle. So I will go ahead with the examples here. So in this patient presented with about esotropia in the right eye, following an injury which happened about 10 years back. So you can see the movement in the in the right eye is, movement of abduction is limited in the right eye. So we did the FDT. FDT came to be totally positive for the tight medial rectus. Then as we have to plan for the surgery, I have done the FGT here, which is the force generation test. So you can see the adduction is fully possible in this child. And you hold the forceps on the area where you have to check, ask the patient to look into the direction of gaze. You will feel the tug on the end of the forceps, which implies that the muscle has still an action. So this will help us for the planning of surgery. Of course, it is not complete without an anterior and the posterior segment examination. You may pick up the sensory status of the child. The child may be having a corneal opacity or a cataract, which might be the reason for the squint he has developed. So always look into the anterior segment and also into the posterior segment. The child may be having the retinal detachment, macular scar or Fort's disease or any other dysfunction. Of course, posterior segment also gives us a clue about the torsion the child is having if there is any oblique muscle dysfunction. Then we come to the provisional diagnosis, which will be the type of squint, the laterality, comitant or incomitant, whether there is an amblyopia present or not, refractive status and the sensory status of the child. I'll take you through few examples. Here this patient presented with a sudden onset of squint noted by the parents for a few weeks time, and they gave the history of intermittent squint in this child. On seeing, you can see the child appears to have an orthotropia. Then we did the stereopsis. As I told you, stereopsis is the first test. The child was able to see able to pick up the wings of the fly. Then we did the Worth-Fodot test, which came to be normal. Then we proceeded with the PBCT, prism bar cover test. Here we have to make the child wear the refractive correction and then do the cover, uncover and the prism bar cover test. So you cover one eye, look for the movement. You can see the left eye has moved in to take up the fixation. So the right eye, you can see the right eye is remaining to be there. Sorry for that. Then you do the alternate cover test to break the fusion completely. Then you place the prisms in front of one eye. Since it's a comitant deviation, we can place a prism in either eye. If it is an incomitant deviation, you have to place in front of the eyes with the problem. So the diagnosis here is an intermittent exotropia. So this patient was brought with a complaint of noticing squint in the eyes since birth. So you can notice that the child had a broad nasal bridge here. So we did the cover test. The cover test was not showing any movement both for the distance and the near. You can see we can just use a thumb finger to just occlude the eyes. So since there is no movement noticed with the cover test, we have diagnosed it to be a pseudostrabismus. This patient was brought with a complaint of squint noticed in the eyes for 1 week following the vaccination. You can see the child is sitting in the mother's lap comfortably. This is the main trick to make the patient cooperate for your examination. Then you can see that there is a face turn. So the child is having a face turn of left face turn with a mild chin down posture. Modified Krumsky test, because the child was not at all cooperative, I got a MKT of about 30 prisms of an esotropia. Here you can see the movements. The movements are full except for the left eye, which showed a limitation in the abduction. Of course, the adduction also showed the same limitation of abduction in the left eye. All other movements are normal. So the diagnosis of a post-vaccination 6th cranial palsy was diagnosed in this child. Coming to this patient presented with the acute onset vertical double vision noticed for the past 1 week time. She was a 35-year-old female. You can see with the versions, there was a slight underaction of the left superior oblique when compared to the right superior oblique here, if you can notice. Then we went and did the cover test in the forced primary position. So the patient had an AHP. We have to force the patient into the primary position and start doing. And you have to elicit the deviation in all the different gazes. You can move the head in the directions to get the deviation in all the cardinal positions. You can see the patient is wearing the glasses, so always adjust the glasses so that the patient is comfortable. You have to do in all the directions of gaze. So here I could see in the primary gaze there was about 6 prisms of right hypertropia, which was increasing to 7 prisms in the left gaze. And in down gaze she had 8 prisms of right hypertropia. On the right head tilt she had 8 prisms of right hypertropia. On left head tilt it was 0. No, it was an orthotropia. And also we have to measure in the near gaze. So near gaze came to be a 4 prism of right hypertropia. So then we did the Hess chart. Of course, with the PARC 3 test, it was confirmed that we are dealing with a case of right superior oblique palsy. You can see the PARC 3, we can confirm it with the Hess charting and the diplopia charting. And the double Maddox rod test also showed a 5 degrees of an exhaustion. So when we proceed with the case of a strabismus, first we have to start with the history, go out with the sensory evaluation, visual acuity, then motor evaluation, which includes the Hirschberg, MKT test, cover test, Prismbar cover test, versions and the ductions, and then comes the special test, then anterior segment examination, cycloplegic refraction, and the posterior segment examination. Once you complete all these things, then you will have your better picture of the strabismus in the child. So a thorough evaluation of the squint is vital for accurate diagnosis and management. Repeated practice and correlation with the clinical cases will strengthen the confidence and competence in squint evaluation. Thank you.
Thank you, Dr. Vidya. It's a wonderful presentation. I really appreciate it. It was very practical. You have shown a lot of videos where you have shown how to perform the test. Few things I would like to emphasize here, which she has very nicely highlighted. One is the fixation preference. This is a very simple test but very powerful test. Even if the child is not able to read anything, doesn't know any alphabets, or totally uncooperative child, still with just the fixation preference you can know whether the child has amblyopia or not. So it's a very, very powerful test. Second thing, as she has highlighted, the sensory test has to be done before you start the motor test. In fact, I would say even before checking the visual acuity, where you are actually going to dissociate the eyes, you test the sensory test first and then probably go ahead with the other things. So that's very this thing. And the third important thing I need to highlight is the cycloplegic refraction. No strabismus evaluation is complete without a proper cycloplegic refraction. And what agents, Dr. Vidya, would you use for cycloplegic refraction?
Sir, I use less than 5 years of age HAT drops, the homotripin drops, and more than 5 years I use the cyclopent drops.
And only thing is with cyclopent, you should be careful with the cyclopent hallucinosis. So some children end up with hallucinosis, so you should be careful how many drops you are instilling. And other important thing is the fundus examination, because I have seen a lot of patients coming with the strabismus, and when you see you have a macular scar or some optic atrophy. So fundus examination is extremely crucial in evaluating a strabismus. So suppose somebody wants to start a strabismology practice, or even for a general ophthalmologist, you want to start squint practice, what are the basic minimum equipments that we need to have in the clinic?
So everybody will be having the vision charts proper. Along with that, they should get a near visual targets, prism box or a prism bar, along with a lot of toys to check the chart.
Yes. So
and the stereoscope chart if possible.
If possible, correct. It's better to have a stereo, because strabismus practice is one of the simplest. Suppose you want to start your cornea practice or a retina practice, you need to buy so many equipments, expensive. But strabismus you can start without any of expensive equipments, with basic minimum equipments you are able to have in your clinic. Any questions for Dr. Vidya? Thank you, Dr. Vidya. So next I call upon Dr. Kavita, who is again a senior strabismologist practicing at Shankara Eye Hospital, Shimoga. So she'll be telling us about horizontal strabismus. So this is the most common form of strabismus we as general ophthalmologists see in our clinics. So she will tell us how to go about assessment of the strabismus as well as management. Over to you, Dr. Kavita.
I thank Dr. Arun for this opportunity and AOS also. I have no financial interest in this presentation. Few of the initial slides of my presentation has been covered by Dr. Vidya. Thanks for that. I just did an analysis of my students. This is just to understand how much we understand strabismus. So what are the various difficulties? So 100% of them told difficult to understand complicated squints, especially little bit restriction is there, paralytic squints. The typical horizontal deviation, that is esotropia and exotropia, they are okay with it. But if they find some limitation somewhere in 9 gazes, they find it difficult, and all 100% said it's very difficult. Children, they are not cooperative, but nowadays we say that we shouldn't use that children are not cooperative, but we should have some method to understand how to examine these children. Mind block 80%, tests are very confusing and difficult, but Dr. Vidya made it very simple. Difficult to diagnose, of course, if you know the findings, then I think automatically we will read and then we can make a diagnosis. Difficult to perform the test, about 80% of them. This is just, I wanted an awareness about how our students feel about strabismus. So the first clinical pearl, that is before I go into the management proper, is to detect amblyopia and the severity of it. We have to treat irrespective of the type of squint. The refractive error and amblyopia management is very essential. All this has been covered by Dr. Vidya. Prism deviation, yes, very important to do it for both for distance and near. Before I take up any patient for surgery, I make a note of 3 readings before I really finalize on what to do and how to go about. Yet another parameter that you have to look into in examination is the type of patterns, the A and V patterns. So these pictures, some of them I have taken from the American Academy. I would suggest that these pictures be taken, and for the beginners to understand the pattern, we can draw a line and check it out. So the primary position, up gaze and down gaze, these 3 positions are the most important to understand whether there is a pattern, esotropia, or V eso, or A exo, or V exo. So this is something we have to practice as a beginner. Now classification of, I'm just covering 2 basic or the common deviations, that is exotropia and esotropia. I'm not covering on the paralytic squints or the restrictive squints. So classification depends on the deviation that you get for distance and near, and you find the difference. If both are same, then it comes under the category of basic type, and if the near deviation is more in exotropia, if the near deviation is more, then you can think it is convergence insufficiency is prevailing there. And if it is more for distance, then it is the divergence excess type. So this is important so that we can understand how to go about if we want to plan for surgery. Yet another simple test, but helps in making a clear-cut diagnosis, is the patch test in exotropia, be it intermittent or constant. If you find variable deviation, better to do patch test. This is, I think, I don't know Vidya covered it or not. It's a simple test where we can rule out the difference between true divergence and pseudo-divergence excess. So you patch the eye, one of the eyes, and then you measure the deviation both for distance and near after 45 minutes typically. Then you understand if there is no difference in the deviation both for distance and near, then it is true divergence excess. In case the near deviation increases, that means the exo becomes more, that means this is a condition that you are dealing with is pseudo-divergence excess type. Now let us look at the non-surgical management, is to first to understand if there is good control of the squint. So whether it is good, fair or poor. In this situation, it is best to observe these patients. Probably you could tell the parents to observe the child for the kind of deviation, the kind of, when it is present, the frequency, and the child's activities, and a regular follow-up is what is required for these kind of children who have good control. And also, Vidya has mentioned about stereopsis. You always monitor these children on stereopsis. In case the stereopsis decreases, this is one of the indications that we will take this child for surgery. So initial intervention is, first is full refractive correction. This is the main thing, whether in any type of squint. In exotropia, we can consider the over-minus therapy for selected intermittent cases, amblyopia management as I mentioned, and in some cases like where there is convergence insufficiency, we can think of orthopic exercises. Where do we think that this child needs surgery? Where there is poor control. In other words, stereopsis is decreasing, increasing frequency of deviation, and it is progressing and it's becoming more constant. There are two schools of thoughts as far as surgery is concerned, whether to tackle these children at early age, that is less than 4 years as far as IXT and exotropia is concerned, or late surgery, that is more than 4 years. So let's look at the advantages of early surgery. Definitely we will be aligning these eyes at an early stage. Therefore, these children develop better fusion and binocular single vision. So this results in a better sensory motor results are obtained following surgery. This also reduces the risk of recurrence. However, there are few disadvantages. There can be a tendency of overcorrection, or if the child is too young, you may not get the correct angle of deviation. Therefore, there can be overcorrection or undercorrection. And in case there is overcorrection, then this child can develop monofixation syndrome, and therefore we will be inducing amblyopia. This is one clinical importance. This is what I want to stress here. So it is better to take 3 readings at 3 different times or 3 different days and establish a constant measurement so that we can plan the surgery. On the other hand, late surgery, the advantages are the measurement obtained are more constant because the child will cooperate for your measurement. But the disadvantages are there is poor sensory outcome, there is increased recurrence rate. In either ways, if there is under or over correction, we can think of Fresnel prisms for these kind of situations. Now let us look at the surgical guidelines. This is what I follow. In the basic type or the divergence excess, I prefer to do bilateral lateral rectus recession, but in case the parents want the deviating eye or the most often if one particular eye is deviating more often, then they will want only that eye to be operated, then I switch on to single eye surgery. Small angle, I would prefer a unilateral recession with resection. Large angles, it's usually bilateral lateral rectus recession with additional one muscle medial rectus in the most commonly deviating eye. In convergence insufficiency type, I would prefer the medial rectus resection. The goal of the surgery is to align these deviated eyes, make them orthotropic or near orthotropia, that is less than 8 prism diopters. Now coming to esotropia, we have various types. The common types are the infantile, accommodative, non-accommodative, acute acquired, and sensory ET. All this clinically you have to arrive at a diagnosis. And here again we have 3 types: the convergence excess, that is if the difference between the near and the distance deviation is more than 10 prism, we will put it under the category of high accommodation convergence by A ratio. Divergence weakness is distant deviation is greater than near. Basic is both for distance and near, it is almost the same. See, this type of strabismus is very important before you plan for surgery. So now let us consider the first thing is the refractive error management. You prescribe the full hyperopic correction after whatever readings you find on the cycloplegic retinoscopy. That means you do not deduct for the distance, okay, or the medicine or the drug that you have used. prescribe bifocal specifically for high AC by A ratio. This is bifocals, that means the near segment is having an additional plus diopter. It can range from 1.5 diopters to 3 diopters. Here what I do is, I balance it with vision as well as the deviation. Deviation also should nullify, as well as the near vision also should be good for the child. So anywhere it ranges between 1.5 to 2 diopters. I make it a point to always reassess the deviation while the patient is wearing the glasses every time the child comes to your OPD. As I said, amblyopia management is yet another important aspect in our day-to-day practice. Now how should this bifocal be? Usually it is the executive type, that is the lower half of the segment you have a linear line which is catering to the near reading distance, and this caters to about 2 to 2.5 diopters. Nowadays we have our opticals people not making this executive type, so I prefer the D bifocal, which is a little wider and has a higher segment, about 35 millimeter. Now when and whom to operate these children with esotropia? As I mentioned, it is the non-refractive or the infantile esotropia. Partially accommodative esotropia is the children with, you have given the plus correction, but still the esotropia is remaining. So these children come under the category of partially accommodative ET, and you follow these children, repeat the refraction and then come to a conclusion whether they are really partially accommodative ET. Then you can think of operating these children. Children who are worsening with bifocals are the ones who come under category to be operated. Why should we operate any of these children with squint? It is to maintain sensory as well as motor fusion, maintain or improve stereopsis. The stereopsis, every time the child comes after surgery, we need to follow up, then we will clearly understand how the stereopsis is improving in every visit. And to normalize the AC by ratio also, we should think of operating these children. Now as far as esotropia is concerned, what are the surgical guidelines? Basic esotropia, I prefer the bilateral medial rectus recession. Small to moderate angle, we can think of doing recess and resect in one eye, usually the amblyopic eye. And infantile ET is, if there is association of inferior oblique overaction, then I would prefer to do bimedial recession with inferior oblique thickening procedure. Partially accommodative ET, make sure you get the correct deviation after the child is wearing glasses, and then you operate for the residual angle only. And this, what is important is to explain to the parents, take 3 photographs before the glasses, what was the ET, make the child wear glasses, take another photograph, and then tell that this is the angle that you will want to operate. High AC by ratio, you do bimedial rectus recession with posterior fixation of the medial rectus, that is the Farden procedure. Alternatively, you can recess additionally by 1 or 2 millimeter. This is an alternate procedure. As you can see in this picture, this is a child with right ET, and after glasses it is reduced but not completely. So I took another 4 to 6 months to understand if it remained the same, and then we operated this child, and now her eyes are orthotropic. Now what are the few factors which really predict the outcomes following surgery? Refractive error correction and compliance with spectacle wear, which is the most common clinical thing that there may not be compliance at all, especially so in accommodative esotropia. Patient sensory binocular vision is another important factor which affects the outcome of surgery. Patient's motor fusional potential, angle of deviation, especially if there is near and distance disparity. Additionally, if there is oblique muscle dysfunction and dissociated vertical deviation, which will be associated when the child presents or it develops after surgery, every time you need to follow these children for horizontal deviation as well as vertical deviation. And if there has been a previous history of strabismus surgery, please keep in mind. all these factors, they will do really affect when you operate on this child. Duration of misalignment is yet another significant contributing factor. Now let's come back to few surgeries. This is the hangback recession which I do commonly. So I'm just taking the fixation sutures. I sit on the temporal side. Earlier I used to sit on the head end, but later I shifted to the temporal side. So I take the fixation suture at 12 o'clock and 6 o'clock using the black silk thread. I'm hooking the muzzle. These steps are common either you are operating for recession procedure, irrespective of the muzzle that you are dealing with. So just take a bite at the lateral part of the muzzle. Similarly on the superior part. First the partial thickness bite and then the complete thickness so that you don't lose the muzzle. Some of the fibers of the muzzle can slip back. This is hang back, so I am not going to suture exactly where this muzzle needs to go. Instead I will be taking a bite at the original insertion so that the muzzle is now hanging back, and then take the measurement, the desired measurement that I want the muzzle to go back, 6 or 7 millimeter. 1 millimeter of recession gives approximately a correction of 3 prism diopters in my hands, and resection it corrects about 2.5 prism diopters. Sometimes I just take a fixation suture at, using Aioc vicryl where the muzzle is hanging, just the direction doesn't change, but it's not mandatory. I recheck whether it's the same and then close it up. So this is the hangback recession. Now this is the conventional recession where we take bite on the sclera where you really want the new insertion to be. So this is a difficult situation, especially you are doing a large recession. Say for example in case of lateral rectors 9 millimeter or 10 millimeter, or in where you want to, you are dealing with high myopes where the sclera is thin. This will be difficult thing. You might even, pierce through and through the sclera. Ask your assistant to hold this knot because it tends to slip here. And then you throw the knots. Usually about 4 to 5 should be sufficient. And then you can close up the conjunctiva with Aioc vicryl interrupted suture. Now coming to resection. Resection is the strengthening procedure. You see the prominent blood vessels here. Take care not to pierce this because it starts bleeding. Some of the eyes, especially in restrictive conditions or long-standing esotropias, adult squints, there is a higher tendency for these muscles to bleed when you pierce the blood vessels. So avoid these blood vessels. Take bites on either side of the muzzle. First the partial thickness and then the full thickness. This is 6O vicryl. It is absorbable suture. You can use a single arm as well. I take one bite even in the middle part of the width of the muzzle so that the muzzle doesn't hang back. I make sure that all the attachments, the intermuscular septum and the muzzle sheath is well separated so that, this muzzle has to come back to the original insertion. Then the desired muzzle measurement that you have, considered, in that area you cut the muzzle and the remaining steps are similar. You take a bite at the stump. Make sure you take a bite, partial lamellar, bite of the sclera as well, so you get better fixation. So I have 3 bites here. You can also use single suture, but then that somewhere it gets cut, you will lose the muscle, so better avoid this. I think this is the safest procedure. Make sure that the whole width of the muzzle has attached to the original insertion. That is the key point here. So that, any part of the width of the muzzle shouldn't be hanging back. Then it will have the recession effect and you will not get the desired results. Now the last surgery that I want to show is instead of resection.
Dr. Kavita, we'll cover in that last talk.
This one is
we'll cover in the last talk.
I'll quit this like this.
Yeah.
Okay. This is an alternate to resection, which now we are doing that. Here I would like to end this.
Thank you, Dr. Kavita, for the wonderful talk. Any questions for Dr. Kavita? Okay. Suppose a 2-year-old child comes with an esotropia. Would you do cyclopaint refraction or an atropine refraction? Atropine. So that is a take-home message. All children who come for the first time with an esotropia should have an atropine refraction, especially the younger children, because with cyclopentalate we tend to miss the hypermetropia. So always better to do an atropine refraction. And how do you monitor intermittent exotropia? Suppose the child is coming to intermittent exotropia every 3 months or 6 months. So are there any parameters you monitor, any scoring system which helps you to monitor and decide whether the child needs a surgery?
The simplest is I ask the parents to take photographs on the mobile. Keep a record on how many times the deviations are seen by the parents. So that is the simplest thing, and if the deviation is increasing, they will obviously know. And I have certain pictures taken and kept in the laminated sheets. I show them what is esotropia, what is exotropia, and then I show them videos, how to make videos, and how to take photographs of the child. So the problem is with intermittent XT, they can never identify that the child is having deviation. So we have to teach them what is esotropia, what is exotropia, how the eyes turn in and or out, and the number of times that the child deviates. And then the distance, whether the child is having good control for near, and then you ask them, I make them practically see the child at a distance when we are observing. I ask them to see the child also at home the same way. The other thing is they can document and keep the number of times.
So whenever a parent comes with a child with a strabismus, the parents will tell there is a strabismus where when you are seeing, you will not see any squint at all. The child will be absolutely straight. So there are two conditions. One is an accommodative esotropia, other is an intermittent exotropia. So these two conditions are common conditions where when you see the child in the clinic, you may see the child doesn't have any squint, but the parents will keep telling that there is a squint. So for this, you should use the accommodative target. And second thing, for the exotropia, you need to check at the distance fixation. Just take him out of the room and show him a distant object like a tree or something, and then you do the cover test. So there you will find out. And to monitor that one, two things. One is the drop in the stereo acuity. Suppose you are following the child every 3 months, and if there is a drop in the stereo acuity, that is an indication for intervention. And the increasing frequency, like typically we say more than 50% of the time that the child is awake. That is one of the other indications that the child might need the surgery. Thank you. We will go on to the next talk. Dr. Soumya, she will be talking about vertical strabismus. So most of us, when we see a vertical strabismus, we will get confused what to do, how to proceed. So Dr. Soumya will tell us how to simplify the approach for seeing a child with vertical strabismus. And by the time Dr. Soumya is getting ready, the hangback recession, one problem with hangback recession is if you are doing large hangback recessions at 8 millimeters, 9 millimeters, you are not sure where the muzzle will go and finally end up. So that's why you should be a little careful with hangback recession when you are doing for a large recessions. Probably you can do something called as a modified hangback in those situations, where you take a thin bite in the sclera at the desired endpoint, and then attach it to the insertion.
Good afternoon, everybody. Thank you, Arun sir, for this opportunity and the AIOS. We would be discussing with vertical strabismus should not be missed. So how we would go about this talk is having an overview. When we look at the vertical strabismus, we should know what are the muscles involved for the vertical movements of the eye, which are the two recti in each of the eye, which is the superior and the inferior rectum. We have the two obliques, there is the superior and the inferior oblique. Clinically, we can have a range of vertical strabismus which can occur, which can be paralytic, which can be superior oblique or inferior oblique palsy. It could be double elevated or a double depressor palsy, or it could be a third nerve palsy. You could have a restrictive strabismus like a TED, blowout fracture of the orbit, Brown syndrome or orbital tumors. Others like myasthenia, DVD, skew deviation, a few of the vertical deviations which are associated with horizontal deviation. Don't get confused, I'm not going to deal with all of this like this way. So overview, first as a general ophthalmologist, as a fellow, what you have to know is how do I know this patient has a vertical strabismus? How do we diagnose if the patient has a vertical strabismus? What vertical strabismus this is? Quick overview of the medical and surgical method of management, other important conditions which are not to be missed. So firstly, how do we identify the presence of a vertical strabismus? How do we know in our clinic that this patient has a vertical strabismus? Look at this child. The child obviously has a right head tilt. So first thing that you have to know when the presence of a AHP is this strabismus driven or otherwise? Just occlude one of the eye, look if the AHP is getting corrected. So you know for sure that this is binocularly driven. Any binocularly driven AHP is strabismus, the cause most of the time. So this child obviously has a vertical strabismus, that's why the AHP. That's your first clue even before you have done an APCT or a Hirschberg or looked at the primary case. The next part of it will be this child has a head tilt, obviously. So put the child into the primary position. Correct the head posture. Just look at the eye, what is happening. Do you see that the child has a left hyper coming up? So that means this child has a vertical strabismus. That's your second clue. Thirdly, the patient has a head posture. If corrected to the primary posture, nothing coming up. Corrected to the opposite head tilt. The patient has a left tilt, move it to the right side, see what is happening to the squint. Do you see that there is a right hyper here? That means the patient has a vertical strabismus. That's your third clue. The last clue, if the patient has a diplopia and you are not able to do an APCT, you don't have any equipment, just use your Medox rod which is there in your refraction set, put it in front of the patient, two Medox rods, place it vertically so that the images are horizontal. If there is a separation of the two images which the patient appreciates, the patient has a vertical squint. So these are your four clues even before you have done an APCT to understand that this is a vertical strabismus. Now let's look at how do we diagnose once we know that this patient has a vertical strabismus, most probably, how do we diagnose it? So this is a patient, when you look at the 9-gauge photograph as a fellow, as a resident, as a strabismologist, you get confused which are the gazes that I look at. So the first thing that you'll look at, simplified. Let's look at the primary gaze. What is happening in this patient? This is the same patient that I showed you earlier. This patient has a right hyper. If the right eye is above, that means the right eye is not coming down or the left eye is not going up. Isn't it? So out of the 8 cyclovertical muscles, we know that the right eye is above, so the right eye depressors are at fault or the left eye elevators are at fault. So that is what we understand by looking at the primary gaze. Now let's look at the second. Look at the right gaze and the left gaze. Do you see the right hyper is there only in the left gaze? So that means out of these 4 muscles which are acting in the left gaze, just mark those 2 muscles which are on the left side. That is the left superior rectus or the right superior oblique, which probably are at fault in this patient. Then look at the head tilt. Look at the right head tilt and the left head tilt. The hyper is more predominant in the right head tilt, so it's obviously the right superior oblique palsy at fault. This is your Park 3-step test. So the first step giving us 4 out of 8 muscles, so you've deducted to 4. In the second step, it is 2 out of the 4 muscles. In the last step, it is the 1 muscle that is left at fault. So that's your Park 3 step for a superior oblique palsy. So what is the fallacy? Can we use it in all the patients that we have? Not really. If the patient has a restrictive strabismus, multiple muscle involvement, a DVD, a skew deviation, previous operated patients, you cannot use a Park 3 step. So this is a test only if it is a single muscle palsy that you are dealing with. Now let's look at the second case. This patient has a right hyper. The patient also has a small amount of anisocoria, probably not very evident in this picture. He came with an acute onset diplopia. Now let's look at what is happening with the ocular movements. Look at the adduction and the abduction. Look at the adduction of the right eye. The right eye is not adducting at all. Look at the depression. The depression is gone in all the gazes, more so in when the dextrodepression, that is in the abducted position. So this patient, look at the Hess charting. Adduction gone, depression gone, the patient has a right XT with a right hyper. So the patient has a right inferior division, third nerve palsy. So your ocular movements and your gaze movements should match with each other to come to your diagnosis. Similar patient, the patient has come to you with ptosis, no complaints of diplopia. He has been like this from birth. Just lift the lid, look at what is happening with the eye. The right eye is downwards, it's a hypo. Look at the ocular movements, elevation is gone in all the position, in adduction, abduction and straight gaze. So this is a case of double elevator palsy or a monocular elevation deficiency. Similar kind of a child having an elevation limitation in all the cases, in adduction, abduction and straight gaze. But more so in adduction, there is no evidence of ptosis. Primary gaze almost okay. So what is your diagnosis on this particular patient? Brown syndrome, exactly. So this patient has a right Brown syndrome. So no AHP, limited elevation more in adduction, superior oblique function normal goes in favor of a Brown syndrome. Now let's look at quick overview of the treatment strategies. So what was the first case that we dealt with? Right superior oblique palsy. So in the right superior oblique palsy, if the deviation is less than 15, what do? Look at if there is an inferior oblique overaction. If there is an inferior oblique overaction, go ahead and do a weakening of the inferior oblique. If there is no inferior oblique overaction, you have three muscles that you can deal with. Either use the superior oblique, tuck it, or you use the superior rectus of the same eye, recess it, or you use the contralateral inferior rectus and match the deviation in the other eye. So that's a simple strategy to follow. If the deviation is more than 15, what do? Combine inferior oblique with any of the three muscles that we have described. So you can mix and match any of the combination to match what the patient essentially has. This is a list of inferior oblique procedures that you can do. You can do a recession, you can do an iliator nankin, you can do an anterior transposition, you can do an anterior nasal transposition. What we did in this patient was an anteronasal transposition. The patient is orthotropic with AHP correct. So that's your management of superior oblique palsy. Case 2 was an inferior division third nerve palsy that we discussed, acute onset diplopia. So what is the first thing that you will do? Young patient, acute onset diplopia, neuroimaging. First find out the cause. We did the neuroimaging. Neuroimaging was completely normal. Patient was started on steroids with weekly taper. What happened to the patient? Look at the patient. The patient is almost, the adduction has come back to normal. Depression is still a little limited. Look at the His chart, completely improved. So this is a case which is post-inflammatory inferior division third nerve palsy recovering with steroids. So neuroimaging, young patient is important for your treatment. The next case is of an MED. This patient also has amblyopia. In any case of MED, what do? You do an FDT as discussed by the previous speakers. So first do an antagonist recession, which is the IR. Then you want the elevation. So put the MR and the LR above, either with a full nap or a partial nap, or you can do a single muscle transposition, or you can do a Nishida. What we did in this patient was a IR recession with a modified Nishida to correct it. Case 4 is of a congenital trans. The patient does not have AHP, does not have primary gaze hypertropia, and it is a congenital condition. So this patient does not need any treatment unless it's acquired, unless it's a significant primary gaze hypertropia. So the patient was corrected for refractive error and followed up. So other conditions which are not to be missed are this. Look at the translucent occluder that I am using. A translucent occluder, whenever somebody is using it, more often than not, it is a dissociated deviation that you are trying to show. So it's a left eye which is going up without a corresponding movement in the right eye. That's your DVD, which is to be looked for. This is another patient where you look at it, you see that there is a superior oblique underaction predominant in the left eye along with small inferior oblique overaction. So this is a case which is mimicking like a IC palsy. Look at the face, the patient actually has a craniosynostosis which is called unilateral coronal craniosynostosis or plagiocephaly in the left side, which again causes a superior oblique-like picture. This patient, obviously, even if you are not a squint specialist, you know that the patient has a glaring appearance at you. This is a case of a restrictive strabismus secondary to thyroid. It requires a thyroid evaluation. Then look at this patient again, similarly elevation limited in all the particular cases. What is more obvious in this patient is the subconjunctival hemorrhage that you are seeing. Look at the face completely. The patient has history of trauma. The patient actually has an orbital floor fracture. So look at the patient wholesome. So if there is any patient coming with hypertropia, symptomatic, look for thyroid, hypertensive, diabetic, orbital fractures. If it's an acute onset, most commonly intracranial pathology or a trauma. If it's a chronic pathology, look at congenital palsies or TED or a myasthenia or a decompensated foria. So periocular swelling, proptosis, TED in the orbital mass, ptosis, look at third nerve and myasthenia. Eyelid retraction, thyroid eye disease, orbital mass, limitation of ocular motility, nerve palsies or fracture. Again, 3-step test for fourth nerve palsy. So if there is quick recap, Any clues, detailed examination, investigate for the cause, treat it accordingly. Thank you very much.
Thank you, Dr. Soumya. It's a very complicated topic, but you have simplified it. What are the indications for neuroimaging in a patient with vertical strabismus?
The firstly would be the age of the patient, any patient less than 40 years of age without any vascular risk factors. Second, if there is multiple cranial nerve involvement. 3, if there is a third nerve palsy and you are following up and you see the superior oblique function getting involved over a period of time, then you would think about it. Or the patient has other neurological issues which are there pre-existingly, then definitely a neuroimaging.
Thank you. Any questions for Dr. Soumya? So the 3-step test is the most important step in evaluation of vertical strabismus. So we have to master that one. It's very easy. It looks complicated, but it's once you understand it, it's very simple. So just the 3 steps you can diagnose which vertical muscle is involved. And most often the most common cause of vertical strabismus will be a supraoblique palsy. That is the commonest vertical strabismus. So you can assume that you see any vertical strabismus first, you just think that it is supraoblique palsy and then investigate further. Thank you. So we'll go to the last talk of today's session. नहीं वो So we have all seen now how to evaluate the strabismus and how to diagnose, and we have also seen the management strategies. Once you have decided that yes, this patient needs a surgery, then how to go about doing a surgery. So that's what I'll be trying to discuss. So I'll be discussing this in these forms. One is the foundations, what all the things we need to know about surgical planning, the algorithm and the core procedures, basically the resection resection which Dr. Kavita has already shown you. Special situations like the obliques and the adjustable sutures, and what are all the surgical wisdoms we need to follow for the long-term success. So I just want the audience to tell me which of these 4 is the most important factor determining the outcome of strabismus surgery. Excellent, excellent, you are very good. So preoperative planning is the most important step. See, surgery, any good anterior segment surgeon can do a squint surgery comfortably without any problem. If you just tell him which muscle to operate, how much to operate, any surgeon can do the surgery. So the most important thing is a preoperative planning. Which muscle to do, how much to do. That is the most important question we need to answer in strabismus surgery. Most of the time the failure of the surgery is either because of the wrong diagnosis, you are not got the correct muscle, incomplete workup, ignoring the restrictions, or premature reoperation. You are afraid of the outcome and then you go for a premature resurgery. So strabismus is basically a biomechanical problem, and we modify the physics in the strabismus. One is we alter the force of the muscle, we alter the lever arm, we alter the arc of contact and the rotational torque. So these are the things we alter in strabismus surgery. So the goal of surgery is just not correcting the eye and bring it to the center, but it is to restore the equilibrium. So we have to correct the misalignment, we have to preserve the binocular vision. So the most important, the goal of strabismus surgery is to improve the binocular vision, and also at the same time maintain full motility, because if you do large recessions or resections, you may end up with motility problems, incompetence. So you have to maintain the equilibrium in these patients. So strabismus surgery, there are 3 things which we do. Either we weaken the muscle, or you strengthen the muscle, or you transpose the muscle. So we'll see what how these things go. Basically, as I said, the diagnosis is most important. So you have to see whether that is a commitant squint or an incomitant squint, because the treatment for incomitant squint is different compared to a commitant squint, and whether it is a restrictive squint or a paretic squint, and is there any secondary pathology. So sometimes there will be, as I said, a toxoplasma scar which is causing the strabismus. So there again your treatment will be different. So diagnosis is most important before treatment. So these are the 6 questions we need to answer before we plan for the strabismus surgery. One is the magnitude of the deviation. Dr. Vijay has very nicely highlighted how to measure that. The stability means, as Dr. Kavita said, I would like to see 3 visits at least to see the stability of the deviation, whether the patient has a fusion potential or not, and whether there is any restriction. And this is one of the most important thing which we often ignore, and previous history of previous surgery. So the AC by A ratio is very, very critical, not only for the esotropia as Dr. Kavita has highlighted, but even for exotropia. So an intermittent exotropia patient who has a high AC by A ratio, you end up with, try to do a surgery, invariably you will end up with an overcorrection, because the child will, because of the high AC by A ratio, the child will go for an esotropia. So ignoring this AC by A ratio can result in very serious problems. And again, as I said, the fusion potential is whether the patient has a good fusion potential or a poor fusion potential. Because if the patient has a good fusion potential, we should be careful in dosing, because if you end up with an overcorrection, the child will have diplopia and a lot of problems. Whereas in a child who has a poor fusion potential, we can go in for a larger correction to get a full correction cosmetically. So indications for strabismus surgery, most often we use the functional indication, either to restore or preserve the binocular vision, eliminate diplopia or treat amblyopia at risk. Sometimes, especially when we are doing in older children or adults, it's for the cosmetic indications, and many a times we have to do surgery for correcting the abnormal head postures. So coming to the preparations, what we need to do, the instrumentation, as I said, strabismus is the simplest subspecialty in ophthalmology to practice. So you hardly need any great instrument. Your simple SICS set is more than sufficient to do a strabismus surgery. You just need to have a few good muzzle hooks and calipers to measure it. Coming to the anesthesia, most often if the child is cooperative, older children or adults, I always prefer to use a peripheral anesthesia. Otherwise, in the uncooperative child, we need to go for a general anesthesia. But the most important thing we need to remember in strabismus surgery is about the oculocardiac reflex. So whenever you pull the rectus muscle, especially the medial rectus is very prone for causing this oculocardiac reflex. So you should be very careful while pulling the muscle, and it's always better to have an anesthetist standby, and if possible you even put an IV line so that you are safe in case there is any problem. The sutures what we use is absorbable or non-absorbable sutures. Most of the time it is the 60 Vicryl, which is the most commonly used suture. And while taking the bites, it's important to know that you have to take a bite so that it is not too deep so as to perforate the sclera, and at the same time it should not be very superficial, because then again it will lead to slipped muscle or even a lost muscle. And on taking the bites on the muscle, we usually take about 1.5 millimeters of the muscle, so that you again don't have a slip muscle or a lost muscle. So there are 2 types of incisions we use. One is the conjunctival limbal incision, other is the fornix based incision. I would prefer limbal based incision for the beginners, because it gives a better access and the visibility is much better. Once you are little confident with the procedures, you can switch over to a fornix based incision, which gives a better conjunctival scar. I think I'll skip because of the paucity of time. I thought I'll have some discussions. So before planning the surgery, one is most important is to have the good preoperative evaluation and plan and exactly decide which muscle to operate. Understand the physics, individualize the dosage, each patient is different, and restore the equilibrium. That is the aim of our surgeries. So coming to the core procedures, as I said, either I can weaken, strengthen or transpose the muscles. So coming to the weakening procedures, the most commonly performed weakening procedure is scission. We also sometimes do marginal myotomy, myectomy as well as the posterior fixation suture. Coming to the strengthening procedures, the commonly used procedures are the dissection and the flycation, and some times we also do a tucking, especially in the superior oblique muscle or as the advancement. Transposition procedures usually are done to change the direction of the vector. So suppose we have a 6-nerve palsy, a lateral rectus is not working at all. So we shift the superior rectus and the inferior rectus to act in the direction of the lateral rectus. So This is a Hummel-Scheen procedure where you cut the half of the superior rectus and half of the inferior rectus and suture it at the insertion of the lateral rectus, so that these two muscles will start pulling the eye into the abduction. In Jensen procedure, instead of disinserting it, you tighten this one. But nowadays we most often use something called as the modified Nishida's procedure, where you don't have to cut the muscle and you just suture it near the lateral rectus muscle. Nomograms, there are a lot of nomograms for the beginners to start with, but I would suggest that each surgeon should develop their own nomograms, because each surgeon has a different method of handling the muscle. What Dr. Kavita has done, I will be doing little differently. So you have to develop your own nomograms. So whatever the nomograms you get on the net is basically as a beginning guide, you can follow that one, but it's most important to that you develop your own nomograms for each surgery. So coming to the recession, Dr. Kavita has already shown this procedure. So basically in recession we are shifting the insertion from this point to the point little posterior. So thereby you are decreasing the lever arm, reducing the torque and changing the arc of contact. So this is the procedure for a recession. So this I am demonstrating a limbal conjunctival incision for a beginning surgeon. So you just hook the muscle first, and then you take 2 bites at each end of the muscle. You can also take a single arm suture, take the middle as Dr. Kavita has shown, and this is a different approach, wherein I am taking 2 halves of the sutures, 1 half on this side, 1 half on that side. So you have to take about 1.5 millimeter thickness of the muscle, otherwise you will not be able to secure it properly and it may end up with a lost muscle or a stiff muscle, which is a very dangerous complication of strabismus surgery. So now I am disinserting the muscle, and then I will measure how many millimeters I want to shift the insertion backwards. So at that point we suture it to the sclera. So I would suggest that all of you please do the surgery only under a microscope, because previously we used to do strabismus surgery with a naked eye or sometimes with a loop. But microscope gives a wonderful clarity and it gives the magnification also, so that when you are taking these scleral bites, you should be very, very careful not to perforate the sclera, because it can end up with a vitreous hemorrhage or retinal detachment. So this is the technique of recession. So we have shifted the insertion backwards. Now we will go to the next procedure. Can anybody tell me why this safe limit of recession? I have written 6.5 millimeters for the medial rectus, 9 millimeters for the lateral rectus. What happens if I do more than that? Anybody in the audience? Okay. So basically it leads to restriction. Means if you recess more than 9 millimeters of the lateral rectus, it will lead to incompetence. So patients may have diplopia when he is looking to the extreme gaze. So that's why you should not do excess recession more than the safe limits. Coming to the next procedure, the strengthening procedure, that is the resection. So here we are shortening the muscle by removing a part of the muscle. So this increases it's a shorten the muscle length, increases the tension and enhances the torque of the muscle. So this is the procedure of a resection. So similar to the resection, you hook the muscle and measure the amount of resection you want to do, and then take bites at that point. So again I am using a single suture which is cut into 2 and one on the either side of the muscle. So this will be the amount of muscle I am going to resect or shorten the muscle length. So basically you have to cut the tendon, so that's why here also there is a maximum limit where you can do the resection. Beyond that, if you do, you will be weakening the muscle. So once you have cut the muscle, I suture it back into the insertion. Okay. So resection works best for unilateral deviations, residual deviations after a primary procedure, or large angle strabismus, because most often whenever we try to do a symmetrical surgery, bimedial recession or a bilateral lateral rectus recession for exotropia. But when unilateral deviations are there or amblyopia is there, then a recess resect procedure will be preferable. So other procedure which Dr. Kavita was trying to show was the plication. So here it is a vessel sparing surgery. So the muscle disinsertion is not necessary. So it preserves the anterior ciliary vessels and thereby reduces the risk of anterior segment ischemia. And the other advantage is it is potentially reversible in the first week or 10 days after the surgery. If you feel that there is an overcorrection, you can always release the suture and the muscle will go back to its original position. So it acts like an adjustable procedure. So this is the procedure for application. So just like in resection, we just take 2 bites at the end of the muscle, edges of the muscle. But instead of disinserting this muscle, I am going to suture this muscle to the insertion. So there will be a fold of the muscle left behind. So you can see here I am just taking a bite onto the sclera and then I will be tying this to that area. So this point where I have taken the initial suture, that comes to the insertion. So it gives the same effect of resection, but sparing the vessels. You are not cutting the anterior ciliary vessels. So it is a much safer procedure than resection. Also there is no risk of having a slip muscle or a lost muscle. So initially there will be a hump like this, but over a period of time that will fade away and cosmetically it doesn't give much of a problems. That is the procedure of application. And again, adjustable sutures, probably we do this in most of the time in restrictive strabismus where we are not sure that the nomogram is going to work. So those patients we use the adjustable suture, or sometimes when we have a very small deviations and we don't want to end up with diplopia, or when you are doing a reoperation. So these are some of the conditions where adjustable suture is a preferred method. So here what I do is, just like in a hangback recession what Dr. Kavita has demonstrated, we do the same thing, but instead of tying the suture, finally I just put a bow tie knot so that I can just see the patient after the anesthesia effect has worn out and then see if there is any adjustment required. So I want to increase the recession or decrease the recession and then put the final knot. So you can see here. So I am measuring the amount of recession I want to get and then I put a bow tie knot here instead of tying it finally. So you can see here, this is a bow tie knot. So after this, once the anesthesia effect wears off, you just do a post-operative alignment and then if necessary you can again go and adjust the thing, or if everything is perfect, just tie the final knot like that. So this gives a chance for the surgeon to titrate the dosage if in case he is not very sure about the outcomes. Skip this pole. Coming to the inferior oblique procedures, the last part of my talk. So inferior oblique procedures are done when there is a primary inferior oblique overaction or for supraoblique palsy. There are different procedures. The most commonly used procedure is something called as a recession, where you are going to shift the insertion of the muscle on the same path as the muscle. Wherever the muscle is going, same path, you shift it from the lateral, it inserts beneath the lateral rectus. So from there you shift it towards the inferior rectus. So that is called as a recession. Then there is a procedure called as the anterior positioning, where instead of pushing the muscle on the same path, you put it little anterior. So this corrects the elevation defects nicely. So it converts the inferior oblique into an elevator. Sorry, from elevator to a depressor, and this is something called as the anterior nasal transpositioning. Instead of suturing at the temporal border of the inferior rectus, you put it onto the nasal border of the inferior rectus, and then sometimes we do a nasal myectomy. When these things are not working, you go and do a nasal myectomy where you cut the part of the muscle here, and this is the final one, something called as a denervation and extirpation. This is the inferior oblique myectomy procedure for this thing. So basically what we do is we go for a fornix based incision, and hooking the muscle is the most important part here, because most of the problems with inferior oblique muscle surgery is because of the improper hooking of the muscle. So you just hook the part of the muscle only, and then you usually end up with the residual overaction of the inferior oblique. So hooking the muscle is very, very important. You can see the pink band running there. So that is the inferior oblique muscle. And you should be very careful not to hook either the inferior rectus or the lateral rectus. So for beginners, I would suggest you just first hook the lateral rectus and the inferior rectus and then hook the inferior oblique, so that you are sure that you are hooking the inferior oblique only. So once you put two muscle hooks like this, you can see a triangle there that indicates that there are no more inferior oblique fibers left behind. So in myectomy, we remove a part of the muscle. So I just put two clamps at two ends. So we should remember that this is a very, very vascular muscle, inferior oblique. So when you cut the muscle, it bleeds a lot. So we should be very careful to do a proper cautery when you are doing a myectomy. So I am excising this part of the muscle. So myectomy actually is a sort of, you cannot grade the amount of recession weakening you want to achieve. So it's like a crude procedure. Most often we don't use this procedure, but just for the demonstration I am showing this one. We prefer to go for a recession than the myectomy, and resurgeries are also not possible in when you do a myectomy, because we don't know where that stump is going to retract and get attached. So this cauterization is important. So once you do the cautery, you can just release the clamp, it will just retract. So you have cut the inferior oblique muscle here, so myectomy. Coming to the recession, this is a more often used procedure. So this is a more controlled procedure where you can grade the amount of weakening you want to achieve. So here, similar to the myectomy, you first isolate the muscle, and we first disinsert the muscle and then take the sutures, because the insertion of the inferior oblique is very close to the macula. So while taking the bites, if inadvertently you touch the macula, you might end up with loss of vision. So that's why I prefer to first disinsert the muscle and then take the sutures onto the muscle. And once I have taken the sutures, then I'll insert it 4 millimeters behind and 2 millimeters lateral to the incision lateral border of the inferior rectus muscle. So that is called as the sheath point. So this you can grade the amount of recession. Suppose you want more effect, you can move it little more anteriorly. So the more anteriorly you attach towards the insertion of the inferior rectus, more is the weakening you will achieve. So if it's just a mild 1 plus or 2 plus overaction, you can just do a recession like this. If it's more severe overaction, you can put it more towards the insertion of the inferior rectus. So this is the inferior oblique recession. And the third procedure is something called the antero positioning. So this is this gets maximum weakening of the inferior oblique muscle, because it effectively neutralizes the inferior oblique overaction and converts the vector to a mild depressive force instead of an elevator. So it's often used for DVD when there is a associated inferior oblique overaction. So the procedure for antero positioning is similar to the recession, but instead of suturing it 4 millimeters behind the insertion of the inferior rectus, I am suturing it at the insertion of the inferior rectus. So here again we should be careful that the posterior suture should be little behind, because otherwise it will pull the neurofibrovascular bundle and cause something called as an anti-elevation syndrome. So you can see here I have sutured the inferior oblique at the insertion of the inferior rectus. So these are the core procedures. What are the factors which influence the outcome of strabismus surgery? One is the age and neuroplasticity. Younger the patient, better is the result. The type and magnitude of deviation, I told you we should diagnose whether it is a committant or an incomitant squint. And most important, we should never miss the AC by A ratio. So that's very, very important whether you are dealing with exotropia or esotropia. AC by A ratio is very, very important. Presence and absence of amblyopia and the refraction. So this also makes things very critical, especially if you are doing a exotropia surgery and the patient has a hypermetropia. So then again you should be careful, because you may end up with an overcorrection because the child will start accommodating. So to conclude the surgical pulse I would like to give from this talk is, preoperative planning is the most crucial step. So if you first decide which muscle to operate and how much to operate, that is 90% of the work done, and surgery is only 10% of the work. Simpler is always better. Don't go for very complex maneuvers. Always try to keep things simple. Respect the anatomy and the tissue planes. That's very, very important, because especially when you go and do a resurgery, you will realize that it becomes very difficult. And most important, you develop your own personal nomograms, so that over a period of years you get a more accurate results. Thank you for your kind attention. So I think with that we come to the end of the session. Any questions, any doubts? So final comments, madam, from all the speakers.
I think you have covered everything. The eye is the photographs. Now it's the digital era. So I think the photographs is one thing which I am using maximally now. And you assess the parents.
Yes.
Before you really operate, what they are expecting out of you.
Yes, documentation is very important.
And documentation is very,
Yes,
very important. Each time, whatever you feel about the patient, that also you write down in the file.
Many diminution of vision, means the vision is less in
Yes.
squinting eye.
Yes, sir.
So they want cosmetic correction.
Yes, sir.
So how much time it will remain after surgery, that alignment in a poor visual acuity?
That again depends on the fusion potential, sir. If the patient has some fusion potential, even though child is amblyopic, for a long time, if there is absolutely no vision, then probably within a few years squint will recur, sir. So that's why treating amblyopia is very important. So the aim of strabismus is, one is treat amblyopia, second is restore the binocular vision. So those two are the most important aims. Sorry. Yes, sir. We can do, sir. Yes, we can do the cosmetic surgery, but only thing is we don't know how long it will stay. Yes, usually it remains, sir. Remains. Yes, yes. Dr. Vidya, any comments?
That should be one of the counseling parts. Counseling is very important in strabismus planning. So you first understand what's the expectation of the parents, then you sit and explain what are your outcomes expected out of the surgeries. So with the proper counseling, I feel we should be doing great job.
Yes, very, very correct, because a lot of these patients are under depression. This is the strabismus patients, a lot of them have depression also. So you should assess their psychological status before doing the surgery, otherwise they'll start creating a lot of problems for you, even small things, and especially there may be slight changes in the aperture post-surgery. So that itself becomes a big issue for them. So they'll forget the amount of 45-degree exotropia they had. That one eye becomes smaller becomes the most important thing. So counseling is extremely important. Dr. Soumya.
For the general ophthalmologists and the students out here, strabismus is not actually difficult. It just requires a structured and a methodical approach, as I always say. It's always better that you look and kind of diagnose in your clinic what is there. If you're not able to, we are always there. You can always refer it to a strabismus specialist. The most important part of it would be, as ophthalmologists, when you spread across a word, to the children who come across to you or the parents who come across to you, that children require an eye examination, that information goes to the pediatrician and the circle becomes complete, that younger patients come to us for referral, so that the condition that they come for just a cosmetic surgery at the marriageable age is something that I would not wish to see in the coming years. That should not be this thing, that everybody is aware that we have treated for the vision and the children have good vision. And we are just doing much more than what we are doing as a cosmetic procedure. It's not a cosmetic procedure. It is a vision restoring procedure. It does require for fusion. Coming with AI, with everything in hand, probably we should look at that as a goal for us to work towards.
Botox injection, sir. Yes, there is a role, sir, but it's a temporary phenomena. It usually wears off after 6 months. So when temporarily you want to get some improvement, yes, you can use Botox, especially in acute 6-nerve palsy or in a young infantile esotropia where you're not sure about the angle, variable angles. There probably Botox, yes, definitely has a role. Sorry, sir? Sutureless surgery, no, sir, because you have to suture. Even whatever the sutureless surgery is, sutureless for the conjunctiva, not for the muscle. Muscle suture is necessary because if you lose the muscle, then everything is gone. Yes, madam. Yes, yes, yes. 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 So, yes, sir. Any comment? Yes, sir. Yes, sir. No, regular full procedure. For amblyopic eye, we prefer to operate only on the amblyopic eye. The recess resect procedure is the most suitable, sir. Yes. Sorry, sir? No, 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 sir. No, sir. That is uncontrolled, so we don't want to do that one. Regular recess resect is fine. Yes. Yes, sir.
My name is Dr. Daya.
Yes, sir.
I'm a foreigner with an OCI.
Okay, sir.
So I started doing squint in 1972,
Very good, sir.
and I was been training at St. Thomas's Hospital in Moorfields. I was still young at the time, and I think either one who started limbal incision
Oh.
squint
Very good, sir.
in 1972,
Okay.
and I was trained by Sir Eric Arnott,
Okay, sir.
who did the first phaco surgery, and I assisted for the first phaco surgery in 1972 in London.
Very good, sir.
And I learned doing the limbal incision, which in fact, they were not doing it before, and I found that the limbal incision, they had a very good healing, and very, cosmetically it was looking much nicer,
Yes.
and the incidence of granuloma was much less.
Yes. Yes,
I
sir.
can see now that there is a lot of improvement in this squint surgery, and myself, I don't do much surgery now. I only play golf.
Okay, sir. Thank
And
you.
thank you very much.
Thank you,
So
sir.
this is what I want to contribute about the limbal incision, which is fantastic.
Thank you, sir. It's an honor to have you, sir, here. Thank you. So I think we're positive of time, because the next session people are waiting. We'll thank you all for attending the session.